Good evening, everyone. I request Dr. Uday Phadke, sir, please to be on the dais to deliver his talk on digital diabetes.
Thank you, Chairpersons. Good evening, everyone. What I'm going to do in the next few minutes is to take you on a new initiative in digital medicine. And this is something which will probably improve the interaction between physicians and patients, make the lives of both physicians and patients simpler, particularly when we are initiating insulin for the first time. And this is the question that we really should ponder upon, and what is integrated care in diabetes? How can we use digital technologies to improve integrated care? What is this new app about, which is called the MyDose Coach? And then finally, I'll show you some results from the pilot study, which was carried out in Indian centers. Obviously, this management of diabetes is a full-time 24/7 job, and it's not simple, particularly from a patient's perspective, who has to look at so many things. He has to take a test, he has to have an adjusted breakfast, he has to exercise, he has to still go and work, he has to take all his medications, he has to watch out for hypoglycemia, he has to carry something if the sugars fall, he has to have a weight control, he has to talk to his doctor, he has to take the insulin injection. It's not really all that simple. I mean, we as doctors feel it's pretty much run of the mill, but from the patient's perspective, it's a great burden. And the other problem is that the way diabetes is progressing, the number of doctors is just fast outpaced by the number of patients that are actually entering this whole pool of diabetes. And if you look at the data, the number of patients is increasing so rapidly that the number of endocrinologists who are actually available to take care of these patients are vastly outnumbered. And hence you're going to get people who are relatively less trained in the art and science of diabetes left to take care of the patients. I'm not saying this is bad, and this is how things are going to be. And these apps particularly will suit the needs and purposes of this second tier of people who do not practice diabetes as a complete specialty and who will need assistance from digital technologies in order to better assist their patients in diabetes care. The second important thing is that we have new drugs, but the outcomes aren't improving fast enough. So we have had so many drugs in the past few months, years, yet people are still dying due to cardiovascular disease and diabetes. And the burden of care is actually becoming pretty unbearable. Now in India, we do not calculate healthcare costs because most of the healthcare costs are borne by individual patients. But where this data is available, you'll see that the cost of diabetes care is hugely burgeoning. In this whole thing, the concept of integrated care becomes important. You obviously have medicines on one aspect, and they are absolutely germane to the whole purpose of treating diabetes. But apart from drugs alone, which cannot be everything, you must have big data. You must have data to decide which person would benefit with which drug. And that is how clinical trials help us. This is big data crunching. We also have pharmacogenomics. We have data coming out from different ethnic populations to help us support patient and professional choices. Then we of course have medical devices which have made life simpler for patients by being able to measure glucose, by being able to measure the different outcomes of therapy. We have easily available blood tests to decide how lipids are doing, the creatinine, the urine albumin, etc. But there has to be a connect between the healthcare provider and the patient, and these services could either be on a personal basis, as they are right now, where the patient visits the patient at the doctor's clinic. But this is fast getting difficult to do because of the sheer number of patients, that we need to have services which use connected platforms between these two individuals, the doctor, the healthcare provider, and the stakeholder in terms of receiving the healthcare, that is the patient, to optimize therapy. And when you have the dots connecting all these four things, we have an integrated care. So this integrated care basically aims at bringing together all the critical enablers, the drug devices, the services, the data analytics able to enable people with diabetes to live a life the way they want in a better quality of life and better outcomes finally at the end of the day. The whole idea of diabetes self-management is increasing. Gone are the days when the doctor would tell his patient, "Arey yaar, mera sun, doctor tu hai kya main hai?" This is all long gone. The diabetes patient needs to be empowered because most of the time he is with himself. The time that he spends with himself is multifold than the time that he spends with his doctor. And hence, actually, there is a huge mushrooming of devices, apps, programs, which allow the patients with diabetes to help self-care. So they could be things about diet, it could be about a general diabetes education, things about physical activity, self-monitoring of blood glucose, medication adherence, how to adjust insulin, etc., etc. And this actually uses technology, some of it artificial intelligence, and you'll be amazed to see how many apps there are available on the App Store and the Play Store. And we are actually now, you might say, adding one more brilliant app. But let's go through what we are doing really. The whole idea started off because in an initial pilot attempt, it was found that when nurses collaborated or corresponded with their patients and helped them titrate a dose of basal insulin, and this was done through a simple text messaging over the mobile phone, people found that a greater number of patients achieved their insulin dose or an optimal insulin dose in a median of just 3 weeks. And as JJ was showing you, it's the first 10 or 12 weeks of titration which really matter. After the first 3 months are over, you will find that the patient doesn't adjust the dose at all. If he's pushed in the first few weeks, they actually go on to getting optimized on the basal insulin dose. And this was a pilot attempt to see if the sister or the nurse or the registered diabetes educator and the patient connected through some web-based and mobile technologies could work through this. And there was some data and there was some evidence to support this, which said that digital interventions appear effective for reducing HbA1c levels in patients with poorly controlled type 2 diabetes. These were initial studies. The trials were shorter in number, they were smaller in number. But yes, there was a distinct trend toward improving HbA1c with the use of these digital technologies. Another important fact that has been recognized is the difference in the use of insulin between, say, trials using basal insulin, say like the BRIGHT study or other studies, or the EDITION trials. And you can see here on the right-hand side, the purple or the magenta arms, the amount of insulin that was being used to optimize fasting insulin. And on the left-hand side, across a host of countries, which include developed countries, not just India, you will see that the amount of insulin that the patients use is roughly half of that what is used in actual clinical trials. Meaning to say that almost 45 to 75% of patients who have been initiated on basal insulin are still uncontrolled for the simple fact that they do not optimize their insulin dose and are using less than 50% of dose than actually that is necessary. And this is mainly because no matter how educated the patient is, no matter how much time you have spent in counseling this patient, he is still afraid of increasing his insulin dose by himself at home. And this is a fact of life. And the other fact of life is that if you start with too small a dose, say start with 4 units, I know that it is sensible to do that, to start with a smaller dose and then gradually go upwards, because as physicians we are afraid of producing what is called the first dose hypos and the patient going off your therapy and abhorring insulin for life. But if you do that, the chances that this patient will remain on insulin is actually smaller than if you had put him on a larger dose and titrated him up rather quickly. So there is a difference in that, starting slow and going slow versus starting a little up and going a little fast. Now, if you want to do that, either you would have to call this patient to your clinic every other day and tell him what to do, which is impossible. nor he would not be coming to that to your clinic, and nor would you be able to see him so many number of times. And the answer is digital technology through some kind of an app which would drive this whole process and be a kind of a comforter to the patient who might rely on something to show him the way. Now this is the app called the MyDose Coach, and this is an initiative from the medical technology group of Sanofi, and this is a mobile application to help patients self-titrate a basal insulin along with a doctor-adjusted titration plan. So this is not an app which has got a brain or an AI of its own, which will just look at the insulin doses and the blood glucose levels and tell the patient what to do. This is fully driven by you, by what you feel is right for your patient, as we'll see from the next few screens how to do that. And there is also a web portal for the doctors to monitor their patients as to what they are actually doing and to intervene if they think something is going wrong. So there is a connect from both ends. And more importantly, from a medical legal aspect, this device or this app has a US FDA clearance for a class 2 device. So what do patients and physicians do here? The physician's role is to identify the right patient. Don't use someone from a small village who is not confident or comfortable with a smartphone. Use someone who you think might use web technologies. Create an individualized plan for this patient. That is your responsibility. The way you tell your patient, do it on the app. So you can tell this patient and tell the app that, look, for this particular patient, if the blood sugar is so and so, I need an increment or a decrement in the basal insulin by so many units. And this could be individual based on the patient's age, the comorbidities, the level of aggressive control that you want, and so on and so forth. You know that better. Register the patient with basic informations on the web portal, which is available in your clinic, and start this and devise a plan for the patient. And this plan is then sent to the patient as a link. What does the patient do? The patient downloads the application from the App Store or the Google Play Store. He gets the link to what you have sent him to titrate his dose. His role is very simple. He monitors the sugars, fasting sugar as advice, and inputs the insulin dose, and also does not forget to put in a hypo if it has occurred. That's very important. And that's all that he does, and the app will do the rest. This is the whole MyDose Coach usage journey. If you see here, on the doctor's end, the patient is registered, the doctor creates a personalized dose plan, sends this dose plan to the patient's mobile device. What does the patient do? He downloads the app, activates the dose plan via a link received in a text message, starts checking, recording fasting blood glucose, and definitely records a low sugar if it has occurred. And then there is, of course, a back office portal also, which is monitoring and following up what this patient is doing. This whole thing together is stored in the cloud, and this is actually the integrated care. This is how the physician's console would look. You log in with your own password and username, and this is how you register the patient. Basic questions like name, mobile number, etc. And then there is some personal information based on the age of the patient, the weight of the patient, the gender of the patient, contact information and email, because that's important. And then, of course, you choose what kind of template or what kind of dosage plan you need for this patient. And once this patient is registered, you will see here all the patients that have been registered from your clinic, those who are active, those who are pending activation, those who have discontinued using the app, and so on and so forth. And this is the plan that you choose. I don't know if it's very clear. I'll take a zoomed version of this in the next slide as well. But the whole purpose of this might look a little complicated to you, but let me see if there is this is a zoomed version of the same thing. You can set this on your own, okay? This is not done by the app. This is fully customizable. You say if this patient's sugar is between 70 to 109, it's in the target zone, no change is necessary. This 70 to 109 could be 110 to 140 if you like. If it's an elderly patient where you don't require very aggressive control, you can change all these values and you can change how much increase in basal insulin you want. It could be 1 unit, it could be 10 units, it could be 20 units, it could be 6 units. It's entirely customizable. You can also set what you feel is hypo. For an elderly person with slightly elevated creatinine and who has already got a established atherosclerotic cardiovascular disease, you might say, I don't want the sugars to go down below 80 as well. You could set your hypo limits there and downgrade the plan from there on. And this is what you feed in at your end as the physician. This is your responsibility. This is not seen by the patient as such. The patient doesn't get this, reduced by so much, reduced by that much. He only gets a figure. This is my sugar, this is what I take. So the app actually takes into consideration what you have written or prescribed for the patient and uses it for the patient. This is something which is also fed in, and this is your emergency contact number in case something happens. You could choose to put in your own number or your clinic's number, or you can also allow the patient or encourage the patient to feed in a number of a hospital which is closest to him, where he can actually approach in case of a problem. These additional instructions can be sent to the patient. You can very well write there that if you are experiencing hypos, if you're feeling hungry, if you're sweaty, if you're feeling numb, if you're feeling dizzy, check your sugar and eat 25 grams of carbohydrate. This is something, or whatever you want, or call me, or come to my clinic next day. All these instructions can be customized and sent to the patient. This is the doctor's part of it. On the patient side, the app looks very simple. What it looks like is, you input the fasting blood glucose, you input what your insulin was last day, and the app will tell you your suggested dose is 12 units. And how does this 12 unit come from? This is from what you have told the app to do for this particular gentleman or woman or lady, whatever you want. There is a clear field here of entering a low blood sugar. Because if you don't enter it, the app will not recognize that you have had an hypo in the past 2 or 3 days and will continue to give you the measurements as per your plan. But if you feed in, if you meaning the patient feeds in, there has been a hypo, the patient will be alerted for something different, and this patient will be told that, look, you need to change your plan. You might, it could read like this: reduce your dose, or it could say stop your insulin and go to your doctor next day, or it could just say stop your insulin and just go to the nearest hospital. You can customize this the way you want, provided you have entered this in your portal at the physician's end. So even when the patient says and enters a value of say 43, immediately the app will tell him, okay, if it is 43, eat this, go to your nearest hospital, do not take your insulin, contact your doctor the next day, or something else that you might choose to program into the app. Okay? It might even say, all right, today instead of taking 12 units, take 6 units, but be sure to contact your doctor tomorrow. Or just make it 6 units and continue. You need not contact your doctor. It all depends on what you perceive, how educated the patient is, and how well he can take care of his own hypos. So all of this is customizable, and all the history can be seen as here. You can see daily sheets of what is this patient is taking. This was the sugar on, say, the 19th of July, what dose he took and what it was on 20th and 21st. And on your side of the portal, you will see a clear chart or a sheet which shows how much insulin the patient is taking and what the sugars are. Apart from this, the patient also has all these things: a user guide, a user video, things about data privacy, because many patients now feel that their data should not come out into the open. And there are many apps which, are not actually customized to protect data in that way. So this is something which is also very important. The patient can also set reminder notifications. If he wants to be reminded that you should be checking his sugar at 7 a.m. every day in the morning and maybe take his Lantus at 10 p.m. every night, he will get a customized notification for that. So the whole value proposition of this app from a physician's perspective is that it helps the patient, helps the physician to initiate a patient on basal insulin and get that patient more rapidly into target by an efficient titration protocol. Comfort of knowing that the patient is under control, because you can actually see the patient sugar on a day-to-day on your app as well. And focus time not on just trying to listen to sugars every day, but on maybe talking to a type 1 patient who is extremely brittle. And this can be taken care of the app very easily. For the patients, there is the benefit from the effect of basal insulin, benefit from getting titrated at home. He doesn't have to call the doctor or go to the doctor's clinic and wait in a queue, and having the comfort of getting to target in a short amount of time. Now this was tested, obviously. You can't just have theories on these apps. And there was an India pilot study to evaluate the user experience, both from in terms of physicians' user experience and the patient's experience. And a 3-month pilot study of uncontrolled but uncomplicated type 2 diabetic patients who were prescribed basal insulin Lantus by their treating physicians as standard of care. The starting dose was 10 units at bedtime, and the titration to a higher dose at the discretion of the physician. And these were oral drug treated patients who were insulin naive and in use and in need of some basal titration. Patients who were not tech savvy, patients who were type 1 diabetic or gestational diabetics were actually excluded from this study. And this was the standard titration protocol that was used. Here, customizable titration was not used to keep a kind of a equipoise between all the different patients using the same protocol. And this was a standard thing used. If more than 150, use 4 more. If 120 to 150, use +2. 90 to 120, no change in dose. And if less than 90, -2, less than 70, -4. And patients were allowed to check their sugars for 3 days for the first 15 days. That means an average of at least 2 sugars was taken in 3 days interval to decide on the mean value and decide on the insulin dose. And after the first 15 days, they could do it in 7 days intervals, but do it at least 2 times during the 7 days. And the app would calculate a median or a mean of these 2 values to decide on the insulin dose. And this was finished on about 150 patients. And you can see here that the MyDose Coach user group had a reduction of A1C by -2.7, which is pretty huge, versus the non-MDC users who were generally counseled as they are in our clinics, and their reduction was -1.7. Now this gap of 1 in just the few weeks of use that was observed is pretty significant. And the average blood sugar reduction, the fasting blood sugar reduction, was 59 milligrams per deciliter. That was very, very encouraging. 7% had hypoglycemic event, but there was no severe hypo, no hospitalization due to hypoglycemia. So the outcomes were meaningful HbA1c reduction, a significant fasting reduction of 59. Average time to reach fasting was 41 days, which is a very short time taken, just about 6 weeks, and no serious hypos. Average basal dose after 3 months was about 23 units. So the whole learning was, it's an easy to use app, takes about 20 minutes to initiate a patient. The first patient training and expectation of management, the expectations of the patients have to be very clear. It is engaging for physicians, and although there is initial inertia, once they use it, there is a high degree of satisfaction and a high level of engagement. Insulin titration, as you know, as I showed you, is generally slow in real world studies. MDC, the MyDose Coach aided patients, are able to titrate their insulin better and reach their fasting goal in an acceptable span of time. I showed you 42 days without a high risk of hypoglycemia. and simple and easy to adopt with better patient involvement. So as I was saying you, it's all about integrated care. It's not just about drugs, it's not just about the doctor being the supreme kind of controller in this whole thing. There has to be an interaction between patients and doctors. And if this interaction could happen over a digital app with mobile and web-based technologies, and of course education being the key, there would be a great improvement in quality of diabetes care. Thank you very much.